Good afternoon, Lucas. Thank you for your kind invitation and the invitation of the Serbian Neurosurgical Society. So I will discuss with you today the surgical approach to anterior midline skull-base meningiomas. It's important to define what we are discussing about. We are discussing about olfactory growth meningiomas, planum sphenoidale meningiomas, and tuberculum cellae meningiomas. In fact, olfactory growth meningiomas are most of the time large tumors in contact with the olfactory nerves responsible for neurocognitive disorders and with limited optic nerve compression, but they are also in the vicinity of the vessels. On the other hand, tuberculum cellae meningioma, more posteriorly located, are discovered when they are small because they are in close relation with the optic nerve responsible for compression. They can extend in both optic canals and they can involve all the vessel, especially the ICA branches. When we are discussing about the surgical approach, we have to discuss on one hand the efficiency of a technique and on the other hand the complication rate. Efficiency means the resection rate, means the neurological outcome in terms of olfaction, vision, neurocognitive function. We can also discuss the cosmetic outcome. And when we speak about complications, we speak about morbidity in terms by sample of CSF leakage rate, vascular damage. We speak also about recurrence rate and mortality. Anterior midline skull-base meningiomas can be approaches either through craniotomies or transsphenoidal approaches, but in fact it is also a craniotomy, but made through the nose with an endoscope. If we compare both approaches, transcranial and endoscopic assisted transnasal transsphenoidal approaches, there are in fact two meta-analyses who are interesting to know. They have compared olfactory growth meningiomas and tuberculum cellae meningiomas treated either microscopically transcranially or endoscopically transsphenoidally. If we look to the gross total resection rate, the resection rate was significantly higher for among microsurgical transcranial approach for the patients operated on an olfactory growth meningioma. For tuberculum cellae meningioma, the difference was absolutely not significant. If we look now at the olfaction loss, clearly the endoscopic endonasal approach demonstrated a significantly greater likelihood of olfactory loss for olfactory growth meningiomas and also for tuberculum cellae meningiomas. If we look now to the vision in terms of vision improvement after the surgery, the visual improvement in fact was significantly higher when treating patients suffering from a tuberculum cellae meningioma, treating them through an endoscopic transsphenoidal approach. It was not the case, no difference in terms of vision improvement for olfactory growth meningiomas among the techniques. If we look on the visual worsening rate, in fact, when utilizing the endoscopic approach compared to the transcranial approach, there was a significantly lower likelihood of worse vision after the surgery for olfactory growth meningiomas. If we look to the CSF leakage rate, it's not surprising, an endoscopic approach is significantly highly associated with a leakage postoperatively. In terms of complication, again, intraoperative arterial injury was higher among endoscopic approach compared to transcranial approach when treating a patient for a tuberculum cellae meningioma, and the rate of intra-arterial injury was quite higher, around 5%. It was not the case, no difference for olfactory growth meningiomas. And in terms of mobility, there is no significant difference among the techniques. So finally, what is very interesting to know and to compare is the visual improvement, which is clearly better after endoscopic approach, especially for tuberculum cellae meningioma, and I will focus on that just later on. If we look to the different transcranial approaches that can be used to treat an anterior midline skull-based meningioma, there are anterior approaches, interhemispheric approach, there are subfrontal approach, either unilateral or bilateral, transbasal, and more lateral approach, frontolateral and pterodontal one. You can see there are many things that we can analyze. This table is quite difficult. I will try to summarize those approaches. Coming from the midline, subfrontal approach were developed in the past. There are a lot of variation of this approach. It requires frontal sinus opening. It gives you an axis which is tangential to the anterior cranial base. The olfactory nerves are at risk. It implies frontal lobe retraction with possible brain edema and venous infection in the postoperative course. It gives you a limited access beyond the tuberculum cellae because you are tangential to the anterior cranial base, and you have a limited access, in fact, to the optic canals because the optic canals are hidden. If we look to the different variation and also the results, globally, some studies have reported very interesting results, but only two have compared the different approaches, bifrontal, frontal orbital, or pterodontal approach. And what are the results? For olfactory growth meningiomas, the rate of life-threatening complication was significantly higher for the bifrontal approach, and the mortality rate was also higher. It was also the same in this study published by Majid Sami team about tuberculum cellae meningiomas. The rate of visual improvement was significantly lower with a bifrontal approach, and the rate of complication and the mortality was significantly higher. So by the end, the subfrontal approach is less indicated for anterior midline meningiomas. If we move now to more lateral approach, the frontolateral approach or the pterodontal approach, it gives you a more lateral access. A pterodontal approach gives you even a more lateral access. It means that the angle of attack of the tumor is different, more tangential to the homolateral optic nerve with a frontolateral approach. The interest is to have an axis perpendicular to the contralateral optic nerves, and the more you turn the head, the more you have an access to the contralateral optic nerve, but the more, and it is at the expense of the visibility of and behind the homolateral optic nerve. So some surgeons will prefer to approach on the side of the tumor or contralaterally. By the end, we have to use skull-based approaches in order to reduce brain retraction, make an early decompression, and also allow an early optic nerve decompression. Most of the time, there is an extradural also opening of the optic canal. If we look to the results of the literature, those two studies focusing on the frontolateral approach, published by the group of Erniestemi for olfactory growth meningiomas and tuberculum cellae meningioma, give good results when the vision was normal preoperatively. Nevertheless, 31% of the patients can deteriorate. If the patient has a preoperative visual deficit, 20% improve and 80% were stable. This was for olfactory growth meningiomas. The same center publishing on tuberculum cellae meningiomas on 52 patients with 87% of gross total resection rate, have improvement of the vision in about one half of the patient. 1/3 of the patient are stable in terms of vision postoperatively, and 15 to 60% of the patient deteriorate. The pterodontal approach was favored by Rudolf Falbusch, and he published very nice results on a series of 47 patients with a high gross total resection rate of 98%. When the patient has a normal preoperative situation, then the patient remains stable in all cases. When the patient has a preoperative visual deficit, 80% improve after the surgery, which are quite good results, and 20% deteriorates. I would like now to focus on one of my favorite approach, which is the anterior interhemispheric approach. Why this approach is very interesting by sample for olfactory growth meningiomas. There is no need to open the frontal sinus, diminishing the morbidity. The opening is just above the frontal sinus on the midline. It allows early devascularization of the tumor, and you have access to all both optic nerves. So you can perform a gross total resection, and you are just behind, I would say, the skin and the bone, and you can directly access the tumor and limit the brain consequences. For plano-spheroidal meningiomas, it is the same. With the limited brain retraction, this concern is very important. How to treat this lesion a little more extending on the left side. If you approach it through the side of the more biggest extension, you have to retract more brain parenchyma. If you go contralaterally, the brain parenchyma retraction is very limited, and there is almost no need to use spatula to do that. This is the location of the bone flap. This is the postoperative result, complete resection, absolutely no brain damage. You see, I would say it is a nostril approach. It is 15 millimeters of dural opening. You see how it looks. The principle is to make a debulking and always push the lateral limit of the tumor inside the hole that is created. And you see here the contralateral optic nerve. You see a small arachnoid membrane still covering the optic nerve. And then you see the optic chiasm and the homolateral optic nerve. Very nice vision without retraction to remove this lesion to a contralateral approach. Very interesting also is to access to tuberculum cell meningioma. The big advantages is that you have a tangential access beyond the tuberculum cell, so you can reach easily the diaphragma cell. This is a very interesting case, completely encasing both internal carotid artery and branches, and you can have a full vessel control proximally, but also distally. This is the view that you get to an anterior interhemispheric approach. You see perfectly well behind the tuberculum cell. You have an access to both optic nerve, the chiasm, you have an access to all the vessels, and you have also this access, which is very important behind the tuberculum cell. But one more thing is the access that you have on both optic canal, and I will show you in this video, illustrating the case I have shown with implication of all the vessels. You can have a distal control and then make a proximal dissection. This is the homolateral optic nerve. This is a vessel control in the tumor. This is a debulking. You will see the preservation of all macrovessel in this area. This is the contralateral optic nerve, which comes into view. A blade on the forks, not on the brain. You see the extension laterally to the optic nerve, and you see how you can gently tract, stabilizing the optic nerve, this tumor even extending laterally to the optic nerve. One of the biggest advantages you see is to remove the part inside the optic canal, complete resection. You see the optic nerve completely decompressed. You see the contralateral carotid as well. So this is how it looks after the surgery. The vision clearly improved after such decompression. And so if we focus more on the vision of the patients operated through an anterior interhemispheric approach, only 2 studies are reported for olfactory growth meningiomas and tuberculum cell meningiomas. And what can we note regarding the visual improvement? In the meta-analysis, the rate of improvement was 50%. If we look to these studies, the rate of improvement is significantly higher, around 78%, with a very low rate of complication. It is also the same for tuberculum cell meningiomas. In the meta-analysis, 60% of the patients improve, but if we look to those 2 studies, the rate is around 90% and here around 70%. So the rate of vision improvement for the region I have detailed can be significantly higher with the anterior interhemispheric approach. So for anterior midline skull-based meningioma, preservation of olfaction and vision improvement must be the goals and guide the surgical approach. Transcranial approach still remains the preferred choice in most neurosurgical centers. It can be indicated for any tumor size, irrespective of tumor morphology and vascular encasement. Frontolateral pteryginal approach are associated with a higher gross total resection rate, a good outcome, and a low morbidity. The anterior interhemispheric approach is for me a valid alternative. And finally, the subfrontal approach is more questionable. Endoscopic and nasal approach remains restricted to selected cases. with limitations with respect to tumor morphology and advantages to visual function in selected case. Thank you.